Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Good afternoon, everybody, or good morning or good evening, depending on the world, where in the world you are. Welcome to this ACAM event discussing depression, identifying, supporting in children and young people. It's good to see in the chat that you really are coming to us from all around the world, which is wonderful that it's such an international event and an international organization. I love ACAM. I strongly recommend you join if you're not a member, because it is so helpful to anybody working with children and young people in mental health. My name is Sam and I am your host, chairman for today. I'm not going to talk for too long because we have such a fantastic lineup of people to talk to you today, and lots of information. So let me answer one of the biggest questions so far. Yes, you will get a copy of the slides and a recording of this event within 3 working days of the event finishing. So hopefully by Monday, you will have an email sending you a link so that you can access the recording and the slides. Please use the chat function to pass any comments, network with each other. Let us know where you're from if you haven't already. If you have any questions that want to be asked at the end of the session, make sure you put them in the Q&A. There's a little box at the bottom, so Q&A. Make sure you ask the question in there. Somebody may have already asked the question for you, and I'm going to try and facilitate that at the end, and hopefully we'll get to answer everybody's questions, fingers crossed. So without further ado, I am delighted to introduce the fabulous and the amazing Dr. Irina Kulpin, who is coming to us from Bristol and looking amazing as well, just casually looking fabulous. And she's going to talk to us about depression in children and young people and family risk factors and underlying mechanisms. So thank you, Irina, over to you.
Thank you, Sam. Thank you for this wonderful introduction. So I hope you can see them now.
All good, thank you.
Excellent. So good afternoon. I am absolutely delighted to be part of this exciting event. And I'll be starting this session by focusing on risk factors for depression in children and young people, and mechanisms and processes that may drive these risks. So I thought I'd start with a brief overview of my background and of research. I'm a psychologist by background with expertise in psychiatric epidemiology and a particular interest in child and adolescent mental health. And broadly speaking, my research focuses on intergenerational transmission of mental health risks in families, and also understanding complex mechanisms that underlie this transmission. And I'm especially interested in the role that fathers play in child development, including their mental health across the lifespan. So my research, which I will be describing today, is intrinsically connected to the AVIL longitudinal study of parents and children. This is a large intergenerational birth cohort based in Bristol and the Southwest. I provided a link here if you were interested to find out more about the cohort. For now, I would just say that it is a 3-generational birth cohort study, and the findings that I will be describing today pertain to the data collected with the original Generation Zero parents who were recruited back in the 1990s and their Generation One children. So just a few words, a brief overview on epidemiology of depression in childhood and adolescence. And I'm sure you know that it's a critical period of development where mental health issues are particularly salient or emerge and escalate. And depression in adolescence is associated with a number of negative outcomes later in life, including poorer mental health later on, impaired educational attainment, and also reduced social functioning. And current prevalence rates suggest that 1 out of 3 to 4 young people will meet a diagnostic criteria for mental health disorder, with an average age of onset between 11 and 14 years. So it's worth mentioning that prevalence estimates of subthreshold depressive disorders that don't qualify for diagnostic criteria are generally higher in all age groups in that population. Depression and anxiety are sort of the most prevalent mental health conditions, particularly in adolescents. And the general consensus in research is that the field has now reached maturity when it comes to rates and prevalence of depression in children and young people, and that future research should particularly focus on gaining better understanding on how multiple risk factors interact over time to produce different outcomes for different children, and also understanding better the mechanisms that drive transmission of mental health risks in families. So first of all, I wanted to share some Alsbach longitudinal data with you on levels of depressive symptoms and how they change over time from childhood through adolescence and into young adulthood. So as you can see, initially, from initially low levels of depressive symptoms in late childhood, they tend to increase until the age of 18. And from there, depressive symptoms begin to decline until the age of 22, where they begin to rise again to greater levels than previously observed at age 18. So quite a sharp increase in levels of depressive symptoms, starting roughly from age 13 upwards. And one possible explanation for this sharp increase in depressive symptoms is a multitude of social, psychological, and biological changes and challenges that young people experience during this developmental period, including pubertal development, school transition, the pressure of undergoing multiple exams, and also the changing nature of their friendships and potentially the start of romantic relationships as well. But so far, we're not sure what are the driving mechanisms that underlie this increased risk of depressive symptoms starting from adolescence. So sex differences in mental health are among the most well-established findings in mental health research. There's plenty of studies and solid epidemiological evidence suggesting that girls are at higher risk of depressive symptoms and depression and anxiety in comparison to boys. So among pre-adolescents, even no gender differences in rates of depression or even higher rates in pre-adolescent boys have been reported. But that changes during adolescence with rates of depression increasing exponentially for girls. And there's also some evidence to suggest that males and females differ in their developmental trajectories of mental health symptoms across the lifespan. So this is again exemplified by these Alsbach data, looking at sex differences in levels of depressive symptoms from childhood to young adulthood. And if you look at the figure, the results suggest that from sort of similar initial levels of depressive symptoms around the age 11, girls on average experience steeper increase in depressive symptoms than boys over their teenage and adolescent years, until around the age 20, when levels of depressive symptoms tend to plateau and start to decrease for both girls and boys. So girls also experience, on average, a higher age of peak velocity of depressive symptoms that occur around 13.5 years compared to boys, who on average have an age of peak velocity for depressive symptoms around age 16. So on average, about 3 years earlier for girls than for boys. And I think these findings have important implications for clinical services, schools, and also parents who should be aware that girls are more likely to be younger when depressive symptoms are increasing most rapidly, and boys follow up at a later stage. So moving from individual risk factors such as sex of the child, we also wanted to examine family risk factors and their impact on levels of depressive symptoms from childhood to adulthood. And unfortunately, divorce and separation rates in UK are high, which often result in biological father absence from the household. And we wanted to examine whether this is a risk factor for poorer mental health. And we looked at father absence as an event that took place either early in life between birth and 5 years, or later in childhood between ages 5 and 10. And on this figure, the yellow curve represents those children whose fathers were absent early in childhood, and the black curve represents those whose fathers were present during that period. So children exposed to father absence in early childhood compared to those whose fathers were present had similar levels of depressive symptoms around age 12, which started to increase from around age of 14, with the greater difference between levels of depressive symptoms observed at ages 16, 20, and 24. So children who experienced later father absence between ages 5 and 10 compared to those children whose fathers were present had similar levels of depressive symptoms up to around age 16, at which point the levels started to deviate. In contrast to early father absence, though, there was no evidence to suggest that there were differences in levels of depressive symptoms between those children whose fathers were absent and present later in childhood at ages 20 and 24. So these findings suggest that early childhood father absence specifically is a strong risk factor for higher levels of depressive symptoms during adolescence and early adulthood. When we examined whether adverse effects of father absence differed by sex, we found that early childhood father absence was a strong predictor of worse depressive symptoms trajectories for girls particularly, but not boys. And at this stage, it's still unclear what factors drive these sex differences, but one of my studies suggests that it may be an earlier timing of pubertal maturation, which is strongly associated with early childhood father absence in girls, and is also a strong risk factor for depression later in life. So we also wanted to examine whether specific characteristics of fathering, not just father absence, are important predictors of depression in adolescence at age 16. And we focused on fathers' attitudes and experiences of childcare, which was assessed repeatedly at 8 weeks, 8 and 21 months, again in the ASPA cohort. And we also wanted to establish whether these effects are are independent of other factors such as maternal and paternal depression, parental social class, and also adolescent experiences of challenging life events. So I just wanted to show you some of the measures that we used in this study. So paternal attitudes to and experiences of childcare were derived from the questionnaires completed by the fathers themselves at 8 weeks, 8 months, and 21 months. So the measures at 8 months, which are not shown here, were self-reports of practical tasks and fathers' attitudes to parenthood. The measures at 8 months and 21 months were identical, describing a wide range of positive and negative responses that fathers held towards fatherhood and childcare. And from these individual items, we derived some scores to capture paternal confidence and enjoyment of the child, and also potential abuse of the child. So we found that paternal reports indicating potential abuse when children were toddlers were associated with approximately 22% increase in depressive symptoms at age 16. And there was also some evidence for an interaction with social class, suggesting that children living in higher social class households with experiences of paternal abuse being at higher risk of depressive symptoms. And these effects were independent of parental depression and other challenging life events that they experienced in adolescence. So the potential paternal abuse measure that we used in this study needs to be validated further, but this study does raise important implications, suggesting that perhaps better insights are needed into the circumstances that predict paternal anger and frustration with childcare, and how this could be mitigated to help fathers to cope better with parenting stress. So we also wanted to examine environmental risk factors such as socioeconomic adversity and its impact on depression in adolescents. And we were particularly interested whether individual factors such as local self-control, for instance, which is an individual's control-related belief system, may explain the adverse impact of socioeconomic adversity on mental health. And we derived a composite measure of socioeconomic adversity from birth to 5 years, which included multiple indicators such as parental education, income, and home ownership. We assessed locus of control with a well-validated measure at age 16, and depression was ascertained using a diagnostic tool. So we found that early experiences of socioeconomic adversity were associated with more external locus of control. So a tendency to kind of hold responsible external circumstances rather than individual efforts. And external locus of control was in turn a strong predictor of depression diagnosis at 18. Although attenuated, there was also evidence of the association between early socioeconomic adversity and depression at 18 once we accounted for individual locus of control. And locus of control explained approximately 34% of the total association between socioeconomic adversity and depression diagnosis. So again, these findings were independent of maternal and paternal depression and didn't differ by child's sex. So the implications of the study suggest that maybe cognitive interventions that kind of address Maladaptive control beliefs in adolescents may be effective in reducing risk of depression following experiences of early life adversity. Sorry. Okay. So parenting and parent-child relationship are also important predictors of long-term child outcomes, including mental health. However, parenting is a complex construct, and it's often sort of cast along three main domains, such as warmth, love, enjoyment, control, discipline, or conflict, as well as stimulation, as in the kind of activities that promote learning that the parent introduces. And although the links between parenting and child outcomes are well documented, the importance of specific aspects of parenting for particular child outcomes has rarely been investigated. So as I mentioned previously, we look at parenting data as some scores, but we also wanted to apply a more sophisticated approach to derive these broad parenting constructs comprised of multiple indicators measured throughout early childhood. And as the first step, we wanted to determine their differential association with later child outcomes at 16, including depression, behavioral disorders, and educational achievement. And we found that conflictual mother-child relationship was associated with greater risk of depression and behavioral disorders, which was reduced somewhat if conflict took place in the context of warm and supportive relationship. Maternal enjoyment, though, did not predict child depression, behavioral disorders, or educational achievement, while stimulation was a strong predictor of better academic grades. So these findings may hold kind of important implications as well for potential parenting intervention, perhaps guiding their focus towards particular parenting domains rather than kind of a general approach, but also understanding better, which parenting domains have impact on which specific long-term child outcomes. So another risk factor which is strongly associated with adverse child and adolescent mental health is maternal depression, which is very common during the perinatal period. Approximately 1 in 5 mothers will experience it. And it's less clear whether these effects actually persist into adulthood beyond adolescence. There's also limited evidence regarding factors and mechanisms that may explain adverse effects of maternal depression on the child. And one such mechanism may be the quality of parenting, especially maternal sensitivity, which is often disrupted by depression and is strongly associated with adverse child outcomes, including mental health problems. Particularly, less attention has been paid to the importance of everyday maternal nurturing activities that are absolutely essential to infant care, such as feeding, attending to crying, and managing sleep routines, and also their potential explanatory role in transmission of mental health risks from mothers to children. Importantly, these basic needs are impossible to ignore. They are quite unpredictable and stressful, as every parent will attest to, and they may be particularly challenging for mothers who experience depression. So in this study, we found that maternal depression was associated with less optimal responses and strategies to manage crying, as well as higher levels of worries about feeding. These dimensions of maternal nurturing behaviors were also associated with higher risk of child depression in early adulthood, and explained the association between maternal and child depression, in so much that once we accounted for all of these behaviors, there was no evidence of an association between maternal and child depression. So research so far has mostly focused on maternal sensitivity and parenting in the context of maternal depression, while the role of paternal parenting and involvement is less understood. And this is a significant omission because paternal involvement may be particularly important in the context of maternal depression because of the role that fathers play in supporting the mother and caring for the child. And in this study, we wanted to examine specifically the role of paternal parenting and involvement and how it plays in the context of maternal depression. So we first derived multiple dimensions of paternal involvement that included child focus aspects. So for instance, father-child conflict, involvement in childcare, paternal parenting confidence, as well as those aspects of paternal involvement that are influenced by the mother and mother-father relationship. And we then examine the extent to which these aspects of paternal involvement explain negative impact of maternal postnatal depression on child emotional and behavioral development, while also accounting for various confounding factors, including paternal mental health. And we found that maternal postnatal depression was strongly associated with adverse child development, but this association was not explained by the combination of all of the pathways through various dimensions of paternal involvement. We found that lower levels of paternal enjoyment, parenting confidence, and higher levels of father-child conflict emerged as strong risk factors for adverse offspring development, with father-child conflict also explaining the association between maternal depression and offspring development. So our findings suggest that both maternal and paternal involvement and mental health need to be considered when one parent is presenting with depression. It may also be important to include fathers in the treatment of maternal depression through partner-assisted therapies, for instance, but it is important to emphasize that maternal postnatal depression remained a strong risk factor for negative child development, even in the context of paternal involvement, remaining a key target for future interventional efforts. So mounting evidence also supports increased risk of postnatal depression in men during the perinatal period, and the estimated prevalence is approximately 10% during that period. My research also suggests that there are strong reciprocal relationships between maternal and paternal depression during the perinatal period and throughout childhood, so-called contamination effect. And increasingly, evidence highlights adverse impact of paternal postnatal depression on child development, including mental health. However, when it comes to the evidence base to understand what are the underlying mechanisms or factors that drive those adverse effects, it's even more limited than research concerning maternal depression. So given our previous findings, we wanted to examine potential explanatory role of paternal parenting confidence, enjoyment, and father-child conflict in the association between paternal depression at this time and several aspects of child development, including emotional problems, conduct problems, peer problems, and also hyperactivity at age 7. So there was evidence that paternal postnatal depression was strongly associated with higher risk of child emotional and peer problems and hyperactivity, but surprisingly, in contrast to previous literature, somewhat not conduct problems. Which was explained by the combination of all of the paternal parenting factors that we took into account in this study. So specifically, paternal parenting confidence was a strong driving mechanism in paternal depression to child emotional problems and hyperactivity association, while paternal depression and offspring hyperactivity pathway was mostly explained by father-child conflict. So again, as in our previous analysis, parental conflict with the child is emerging as a strong risk factor for adverse mental health. So these findings suggest that adverse effects of paternal depression on the child may be driven by paternal parenting and involvement, and future interventions and that target these aspects of paternal parenting may prove fruitful in terms of improving future child outcomes in the context of paternal depression. So I think I will probably stop there. I'm almost coming to the end of the time, and I'll stop sharing.
Thank you, Irina. We have got some points and questions that have been raised, which I'm definitely going to come back to at the end of all 4 sessions, if that's okay. So I look forward to speaking to you very soon. Thank you. And we now have Dr. Alex Boyd, who's coming from Devon. There's a definite southwest of the UK link here, because part of the involvement in organising this was the Devon and Cornwall hub of ACAM, which I am delighted to be a member of. And Alex is coming to us from Devon, and she's going to talk to us about how depression may present in young people and how parents and carers and adults working with the young people can recognise. So over to you, Alex. Thank you.
Thank you. I'll just share my screen. So welcome, thank you. My name's Alex Boyd. I'm a clinical psychologist, and I'm currently the co-director of young people's mental health training at the University of Exeter, and I'm also psychologist in independent practice. So I'm just going to talk you through over the next half an hour about how we can recognise some of the signs and symptoms of low mood and depression in young people. And it kind of feels like we need to start with kind of the rates, and I think that, you know, everybody will be aware really of rates rising and consideration of mental health in young people. And I think over the last 50 years, we've seen quite an increase in understanding about young people's mental health, and in particular depression no longer being seen as associated with just developments in puberty and kind of changes. But what's quite interesting is it wasn't until the 1980s that actually it was considered as a diagnostic consideration outside of adulthood. Depression was only diagnosable up to then by kind of diagnostic standards in adults. So anyway, back to kind of prevalence really. And most recently, NHS Digital have looked at the impact of mental health on young people. And their most recent survey indicates that 18% of young people aged 7 to 16 and 22% of young people aged 17 to 24 have a probable mental health disorder. And so that doesn't just include depression, but I think it does indicate actually the significance of young people's mental health, of the young people we work with currently. When we think more specifically about depression, NICE guidance estimates that in younger children, so 1% of pre-pubertal children and 3% of post-pubertal children will have depression. And then the more you look and the more you assess and the more research there is out there, the varying but increasing rates of other estimates that you can find. And I think in particular, you know, estimates as high as 24% in girls aged 14 years. It's, you know, it is something we do need to be aware of and we do need to support. So I guess it's important to consider that depression and low mood can coexist with other mental health conditions, and in particular often young people who might be experiencing other difficulties, and in particular anxiety or illness or difficulties at home. It's important to consider that actually depression might also be there as well. And I think some of the research has indicated that most cases of depression in adolescents go undetected, that often it's considered just the normal signs and symptoms of teenage behaviour. I think it's important to hold in mind family risk factors, which include family history, increased academic and social demands, negative life events. We've only got to think about COVID being an enormous one of those, family discord, trauma, maybe that's past or present, again, bullying, past or present. And I think when you consider some of the young people you might be working with, particularly in an education setting, you might not be aware of some of the bullying that they may have experienced or trauma in their past if they're new to your setting, or even what might be going on presently in terms of if young people aren't disclosing some of those difficulties. And risk factors also include substance misuse and chronic illness. So what's it like to be a depressed teenager? So, I mean, you never want to put words into teenagers' mouths. So it's really important that research takes place that does consider the young person's voice. And this particular research study looked at 77 adolescents with semi-structured interviews who were considered to have moderate to severe depression. They'd been referred to a child and adolescent mental health service, but they hadn't yet had any treatment. They'd just had an assessment. So semi-structured interviews were undertaken, and then there were 5 areas that really the young people's experiences appeared to sit within, of which the first one was this notion of misery, despair and tears. You know, young people reported things like, I don't know when the last time I felt happy was, that the way they felt was sort of like a dragging feeling. Participants talked about using self-harm and alcohol and drugs, and to the degree beyond almost what we'd expect or might see as normal exploration. They talked about a build-up of these feelings. The kind of second area was anger and violence towards self and others. Young people reported that they felt their anger came from nowhere. They were angry at teachers, they were angry at friends and peers, parents, as well as themselves, with self-harm, including things such as punching walls, pulling hair, pulling eyelashes, as well as more other forms of self-harm, such as cutting. So again, and then they felt there was a bleak view of everything. And I think there's a lovely quote within this research that really sums that up. And Brian, aged 11, said, I feel like my heart is broken, but somehow I was the one who broke it. This just general feeling that young people experienced, everything feeling quite pointless. And as a result, they felt isolated and feeling almost like they were cut off from the world. So Nicole, aged 17, noted, even when I'm with people, I feel alone. I'm invisible. There's a sense that they are separate from others, yet they are with them. And I think overall, this huge theme of the impact on education, and as you'd expect, you know, education is a young person's kind of occupation. There was a loss of energy, interest, problems getting to school. And then when they were in school, if they, you know, were managing to get in, the difficulties with focus and concentration. And then the subsequent anxiety as a result of that. So almost they were feeling so low they might get to school, but actually in terms of when they then got there, they might feel so overwhelmed with the anxiety of not feeling like they could concentrate. They might be experiencing significant panic attacks or increased anxiety. So they might have made it into school, but the impact on their learning was still really significant. And other studies, so Dundon did a meta-synthesis of 6 studies where they looked at 6 studies that had qualitatively, again, asked for young people's voice and experience of depression. And 6 themes came out from their work, which included beyond the blues, this idea of spiralling down and within, that there were significant breaking points, which included stress-related impact of family life, loss and illness. This idea of being seen and seeing, seeking solutions and taking control. But I think the thing that sums it up so nicely is this idea that young people described a feeling of losing touch with themselves, their friends and their family, and that the depression took over. And with it taking over, it increased this idea around pessimism, it decreased their self-esteem, that, you know, they had increased fatigue, that they felt angry, and there was an overwhelming sadness that it left. And I guess in drawing all those studies together, the causes that were attributed to this was stress and transitions, and namely the kind of transition from childhood to adulthood, alongside trauma, relationship difficulties, and the biological impact of everything that goes with being an adolescent. So what would we look for? Some of the same things, really. And I guess when we think about the signs and symptoms, we want to be really thinking a little bit about the child in front of us. How much do we already know about that child, and what else would we look for? So children might appear unhappy. They might just not seem themselves, and that might be present for quite a while. They might actively report feeling hopeless or helpless or miserable. They might be experiencing increased irritability. And irritability is one of the indicators of a diagnosis of depression in young people, specifically for young people, not adults. And so it's really important to think about what irritability might look like, might appear like, you know, how would we describe it? And then how might we see it in the young people we're working with? Have they experienced a loss of enjoyment in things they had previously enjoyed? Have they started to withdraw and stop going to things? Is it just a real shift in that idea that actually we used to laugh about X and now we don't, if they're, you know, a young person in your family, or even that you know well within the context in which you work? Are they tearful, and are they experiencing more tears or becoming more tearful more easily? So are there smaller things, almost that idea that the bucket is overflowing a little bit more easily? Is there a sense of sadness about them? Are you witnessing or seeing kind of cognitive changes, particularly around concentration, the idea that actually they might be struggling to process instructions that they're being told? Are they finding it hard to follow through what's needed within the lesson? Are they present at the dinner table, but are they actually not present when you're asking and talking to them? And is this a pattern that is going on? Are they experiencing a reduction in their confidence, things they might have previously done? Are they now suddenly saying they don't feel up to doing? Are they reporting ideas around self-blame and guilt and responsibility? I think, you know, we know that young people express feelings of shame and self-criticism when they cannot manage the level of kind of activity or social activity that or even academic performance that previously they would have been at prior to the onset of symptoms. Are you seeing sleep changes? And are these sleep changes more significant than what you'd normally see within an adolescent? So are they going to bed at a reasonable time but still really struggling to get up? Are they not sleeping at all? Are they awake all night? You know, what is different? And the same with eating patterns. Are they eating more, or are they eating a lot less? Have you noticed a change? You know, is there a change in the type of food they're eating or looking for? And are there actual indicators of self-harm or suicidal thinking? And, you know, some of that might be more subtle. It might be young people always wearing long sleeves on hot days because they don't want to expose their arms. Are they become more reluctant to show their body because of the self-harm? And then I guess what else should we consider? And I think the really most important thing is what's normal for them. So every young person is different, every family is different, every setting that they are part of is different, but what is normal for them? Has their school performance reduced? Is that consistent across different subjects? Is there an increase in their social isolation? Are they just starting to subtly avoid a lot more? Are you seeing more aggressive or violent behaviour, and almost like that idea that it kind of comes from nowhere? Are you seeing increased physical complaints, you know, more headaches, more stomach aches, more absences due to physical complaints that are maybe less explained? And I think in younger children, we see a lot more physical complaints and more clinginess. You know, also with the slightly younger young children, look for clues in their play. What else is happening? Are there other things going on that we need to really be thinking about, such as family conflict and changes in their personal or family life? Are there difficulties with friendships? And is that consistently ongoing? And are they reporting feeling confused? And I think the idea around this confusion. It's like, how do we explain to other people or other adults what is happening, and when you don't really understand it yourself? And I guess we can hold those main features within these kind of 4 areas, really. Those mood changes, the sadness, the irritability, and what does that irritability look like for them? The social relationships, the avoidance, the withdrawal, the social isolation, the difficulties in relationships, and in particular in finding it harder to problem solve and solve difficulties they might have done previously, whether that's practical problem solving or whether that's relationship problem solving. Those cognitive changes, you know, the idea around concentration, are they saying that they kind of can't do anymore? Are they feeling they're not good enough? Reporting feeling worthless, lacking in hope, feeling helpless, and that increased in suicidal thinking. And then really thinking about some of those physical symptoms, the sleep, what's happening there, the eating, that idea around apathy, like just not knowing kind of how to change or get going, and inactivity. And one of the things we really know about depression is this idea around inactivity can increase, which then increases some of the symptoms. I think it's important to hold in mind that in terms of a diagnosis of depression and thinking about it in its diagnostic terms, we'd be seeing this kind of pervasive shift towards this sadness and irritability. And I guess that increasing loss of pleasure or loss of engagement. And really, we'd be looking at that happening over a number of weeks. I think the Diagnostic Statistical Manual says 2-week period, but I think that it's often more subtle and can go on a bit longer before it's recognised for young people. But I guess the most important thing to hold in mind is that if it meets diagnostic threshold, it has to be an experience that's really different from how the young person usually is, and that it's really showing an impact on the young person's life, so it's causing kind of impairment. And I guess, you know, these 2 cycles really show the impact there is and the ongoing impact. And we know that there's a high level of relapse in young people who are experiencing or have a diagnosis of depression. And as they reckon, as many as 70% of young people experience depression will have a further episode within 5 years. And the long-term risks really around self-harm, suicide, physical illness, substance misuse, and interpersonal problems often persist into adulthood. So we know it has an impact on their social well-being, their emotional well-being, their occupational well-being, and their physical well-being. And I guess this kind of blue circle on one side really shows how that vicious cycle can go on, really. So inactivity, starting to not feel good, can increase the sleep problems, or another symptom of sleep problems, which again, we have more inactivity, which leads to poor concentration, and that symptom, which can lead to poor schoolwork, and then seeing less people, and then increasing that kind of cognitive domain of that sense of failure and feeling helpless. So you can see how those 4 areas of mood changes and social relationships, and alongside the cognitive aspects and physical symptoms, can all interact. I guess what some of the questions that often we get asked is, what's the difference between low mood and feeling blue and depression? And I guess the way to kind of hold that in mind is that feeling blue can be experienced intermittently. It can be short-lived as a result of something which is happening or happened or anticipated to happen. Motivation might be poor, but it will usually pass. The young person can be encouraged to engage, and it will pass. And I guess depression doesn't. It starts to have a significant impact on functioning, their thinking, and their ability to engage. So I guess the important questions to hold in mind if you're trying to identify this in the young people that you work with or that are part of your school is that does the young person appear different to usual, and has this been the case for several weeks? So these questions are really the signs and symptoms that I've just been over, but a nice way to think about it is by holding the question in mind. Has their confidence dipped? Are they more indecisive? Are they not completing homework or engaging in things they might have done previously? Are they reporting fatigue and feeling changes in sleep and appetite, or potentially their physical symptoms? Are they reporting an increased self-doubt, more sense of dread and failure? Are they becoming more grouchy or sulky or getting into trouble at school? And I guess this idea of them feeling more misunderstood. And when you think about the interaction of anger that's reported in young people's experience of depression, that often is not picked up as being related to depression, how is that coming out for them? Are they more absent than usual? And being absent doesn't just necessarily mean physically absent. When you're talking to them, do you feel like they're there? Do you feel like they're finding it hard to listen? Are they present but absent? Are they clingier? Are they finding it harder to go to school? You know, is it presenting as a little bit more, needing a bit more closeness? And actually, is it anxiety where this might have started, leading to low mood and that interaction? We know there's an 80% comorbidity with depression, and usually that's an anxiety disorder. Or are they experiencing a real lack of emotion, that ability to kind of connect, that being seen but not seen, as reported in some of the research? And I think when we consider that more subtle presentation, it's like, how can the young person explain? How can we kind of identify it? And it might be a more feeling of avoidance and empty, that kind of idea around, you know, what that is. I guess don't forget other factors and the impact of that within young people's lives. What else might be happening? What else is going on social media, the interaction with other people, either inside or outside of friendship groups? Is there bullying? Are there wider contextual factors that we need to hold in mind? You know, exams, illness, financial pressures. You know, we can't get away from what's happened in terms of COVID, but what has been the impact for them individually within that? And what else might be kind of contributing? So this is just a case example of Jen, who was 14, who started getting more behaviour points at school. So actually they were starting to get a little bit more considered, a bit more destructive, a bit more stepping outside of their usual behaviour. She started to withdraw from social activities with friends, but she was still going to family events. So it was difficult for families and her parents to know that actually this was kind of going on. They recognised the behaviour points, but actually she seemed herself with them. But what was happening is she was doing less and less with other people. That idea of self-doubt and feeling worthless was starting to creep in. So she started to report when things happened. She thought it was all her fault. And then this subsequently turned into a presentation of more physical difficulties, headaches, increased absence at school, not feeling great, becoming more tearful. She then had an impact on her appetite, and reporting that idea of kind of apathy and lethargy all the time. But actually a teacher asked her, and she was able to tell them. And actually where this then you know went to is that actually she had started self-harming as a way to try and feel something again. But if nobody had asked, I guess the question is, how long would it have gone on before somebody had asked, or how bad would things have got? Because in terms of what she was presenting with, it didn't seem that significant. So what can you do? And I guess it's ask. And, you know, it's not within the scope of the time we've got now to think about significant interventions, but what we can always do is think about it and ask about it. You know, how are things? How have things changed? How are you feeling? I notice you don't appear yourself. Young people have noted in, clinical work, and there's a lot of clinicians on the call today, but also they know in the research that it's really hard to explain, that it's hard to feel that adults understand their emotional experience, really. And I guess being present and being open and being approachable, sitting, connecting and being available is one of the absolute best things that you can do. You can also use scaling questions. So on a scale of 1 to 10, where would you place yourself now, to try and really see how somebody is. You know, don't need words as such. You can just use smiley faces or, numbers. And where would they have been a couple of weeks ago, months ago, or a year ago, and where would they like to be? And I guess just really simply what might help. And it might be that, they don't know the answer, but you're showing that you're available to ask those things. But what do you do when you're noticing all of this stuff in young people, but they don't want to talk to you, and you're trying to be as present and available for them as you possibly can, but somehow you're still not able to almost connect? So, other small things to just remember and hold in mind is being available, and consistently available. Use developmentally appropriate language. You might want to think about drawings and just, put a piece of paper in front of them and say, just draw how you feel. It might be a black blob. Winston Churchill talked a lot about the black dog always being there. This picture shows the rainy cloud and then the puddle with the dark cloud in it. You might get them to describe it as a colour. I don't know how you're feeling, but if you could describe it as a colour, what would it be, and how else would you describe it? And just thinking about analogies and metaphors, such as the weather, is a really good one to really think about how we might describe it. And interestingly, this picture here and the one a couple of slides before both depict a rain cloud, and they weren't prompted in terms of those pictures weren't, can you draw a rain cloud? It was, can you draw what that feels like? And I guess the small steps to then helping and really thinking about it without going into massive detail is connection. Consider activities which give young people a sense of achievement, and that might not be huge things. If they're withdrawing from activity, can it be a small thing to go out somewhere, such as the cinema, or to get to school, or to interact with a group at school that maybe they're finding difficult, and then think about things that might increase their sense of pleasure. So I guess, where else can you access support? There's masses of support out there. I found it really difficult to kind of think about what to put on this last slide in terms of access to things. So there's no shortage of information, but I guess, good UK charities and information come from Young Minds. The NHS website, Every Mind Matters, have got some great stuff for just children, as do the Mind website, the NSPCC. Kooth is a free online counselling service which is anonymous for young people, so it can be quite helpful if they're struggling to share with people they know and they just want to be able to talk to somebody. And I guess those of you who are in the UK, access your local mental health support team in schools, and it's great to see that there are some EMHPs here and people from the mental health support teams. It's a national initiative that is set to cover 100% of schools in the UK over the next couple of years. We're getting quite close to that target in terms of national coverage. So if you don't know about it, you don't know whether you've got one, try and find out. And there'll be a great source of information and provision of therapy for young people in schools. Or find and make sure you link in with your local CAMHS service. I know that our local CAMHS service in Devon have also got some great resources on their websites, and there's lots of local charities. So I didn't want to direct you all too much in that direction when there'll be plenty of access to things depending on where you are in the country.
Thank you, Alex. That was great. A lot of comments in the chat about how useful this was. And it's quite interesting. We've got so many different here, from school workers who are working pastorally with children to, highly qualified mental health practitioners. So trying to meet everybody's needs today is going to be challenging, but your session was incredibly useful. We do have a couple of questions which we're going to come back to at the question and answer session at the end, if that's okay. But yeah, just as somebody with lived experience with depression as an adult, it sounds very similar to the sort of youth experience, and I think you succinctly put it there very, very well. So thank you for that.
Oh, thank you.
We're now going to move on to the wonderful Gabrielle Hale, who is in the South Wales and is going to talk to us about the role of professional football clubs. Alex, Gabrielle, if you just get your slides up again, I just want to reiterate for everybody, yes, you will get a copy of the recording and the slides from today within 3 working days. So don't worry about that. So you're going to talk about a football club for the physical activity element of supporting depression, but yeah, the football clubs, I'm really interested to hear this. So over to you, Gabrielle.
Thank you. Can I just check, can you see my slides?
I can see your slides, yes.
Great, thank you. Okay, so good afternoon everyone, and thank you to the previous speakers for their really fascinating insight into trying to identify depression in children and young people. So my name is Gabrielle Hale and I'm a lecturer in clinical psychology from the University of South Wales. And in this talk, I'm going to outline the role that physical activity programs can have in enhancing the mental health and well-being of all children and young people, as well as identifying those that might be at risk of presenting with a problem such as depression, and then ensuring that they can receive the necessary support. So specifically, I'm going to discuss some of the key findings from my PhD research, which has evaluated mental health programs that are delivered by the community trusts that are attached to professional football clubs in the UK. And with thanks to my supervision team and Cheltenham Town Professional Football Club, who deliver a community-based programme to increase young people's levels of physical activity, enhance their mental health literacy and their overall well-being, and who have kindly partially funded some of this research as well. So as we know, recent evidence regarding young people's mental health is quite concerning, and as Alex pointed out, so the NHS Mental Health of Children and Young People survey that was distributed in 2017, this found that 1 in 9 aged 5 to 16 had a diagnosable mental health condition, which is about an average of 3 pupils in every classroom. And it was also reported that emotional disorders such as anxiety and depression were most common, and these rates did appear to increase throughout adolescence and appeared to be higher in females as well. So a later follow-up survey that was sent out by the NHS in 2020, they found that mental health problems had increased in this age group during the pandemic, with this age group now presenting, 1 in 6 would be presenting with a diagnosable mental health condition. And these increases were seen across boys and girls, as well as at LGBT communities as well. And Cahuan and colleagues, they conducted a review of longitudinal studies from across 11 different countries that looked at the prevalence of mental health problems before and during the pandemic, and they found that most studies found that mental health problems appeared to have worsened during this time, with increases being seen in depression, anxiety, distress and loneliness. But adding to this, another public health concern that we have is young people's levels of physical activity. So the World Health Organization recommends that children aged 5 to 17 should participate in an average of 60 minutes of aerobic activities per day. And they should include vigorous activities that can help to strengthen their bones and muscles for 3 days a week. And it's also recommended that they should reduce the amount of time they spent taking part in sedentary hobbies. So particularly the use of recreational screen time, so things like spending lots of time on their mobile phone or tablet and computer games and so on. It's important to note that there isn't one specific type of activity that is recommended as being beneficial for a young person, and various different hobbies can have a positive impact. So things like team sports, yoga, age-appropriate resistance training, as well as just simply walking to school or helping out in the garden, or just having short activity breaks throughout the day. So not only can physical activity have a positive influence on physical health, but it can also be beneficial for a young person's mental health as well. And evidence has found that young people that are more physically active display increased self-esteem and lower levels of anxiety and depression. So this positive influence is likely due to a range of biopsychosocial factors, such as changes to the structure of the brain, increased feelings of confidence, and more opportunities for social interaction with their peers as well. And we conducted a systematic review of all types of physical activity programs during the early stages of the PhD research. And we found that these various physical activity programs could increase young people's quality of life, body image, and overall psychological well-being. as well as reduce symptoms of depression. And we found that this to be the case across various different types of activities. And we also found that some of these programs, they would combine the physical activity sessions with classroom-based sessions to educate the young people on various topics, such as the importance of eating a healthy, balanced diet, or identifying ways that they can look after their own psychological health and well-being as well. However, though, despite these, the physical and psychological benefits of being active, young people are increasingly leading sedentary lifestyles. And studies have estimated from looking at worldwide data, they've estimated that over 80% do not meet the World Health recommendations for physical activity. And it appears that these rates will decline throughout childhood and adolescence. So it tends to be a common misconception that the declines don't happen until adolescence, but often these studies have found that these declines start a lot earlier than that, with some suggesting as early as 5 years old. And it's likely that there's a variety of different factors that can prevent physical activity engagement during childhood. So preferences for electronic media, spending more time on academic studies, feelings of a lack of parental support, as well as bullying and judgment from their peers as well. So clearly there's a need to try and address these concerns, as young people that are not as active are at greater risk of developing a mental health problem due to the absence of those biopsychosocial factors that can have a positive impact on mental health through physical activity. So clearly we know that these early stages of life are really crucial, and the World Health Organization's Mental Health Action Plan, they advocated the need for effective strategies to promote good mental health in young people and prevent the development of a more serious problem in later life. And the NICE guidelines, they provide recommendations for managing and treating depression in young people. One of the things that they do highlight is that a young person that is with a diagnosis of depression should be offered advice on the benefits of regular exercise and encouraged to follow a structured exercise program if possible. So taking all of this evidence together, it's reasonable to suggest that community-based programs could successfully use physical activity as a cost-effective way to promote overall mental health and prevent the development of later problems in young people. So this led to the rationale for my PhD research, as one potential pathway for delivering this type of work is through the community trusts that are attached to professional football clubs. So firstly, we know that team sports can have a positive impact on mental health because it can increase physical activity levels and provide opportunities for social connectedness. And also the coaches that work closely with the young people to deliver this type of work, they can be trained to identify those that might be at risk of developing a problem or are already showing the signs of a problem, and then can hence ensure that they are signposted to receive that necessary support. So community trusts in the UK, they receive funding from their parent club to deliver a range of different programs to people in their local communities to try and address like various public health agendas. And they use the status of their parent club as well as kind of like a hook to connect with those individuals. So traditionally, these programs are focused on improving health, education, and social issues, so things like reducing youth crime, for example. But more recently, there's been growing interest into the role that they could play in increasing young people's physical activity, developing their understanding of mental health, and preventing the development of problems in later life. So one example One key programme, as an example here, is Mentalk, which has been delivered by Cheltenham Town Professional Football Club. So this is an 8-week programme that is delivered to boys aged 13 to 18 in schools. And the overall aim is to encourage them to be active whilst also teaching them about the importance of mental health. So each session will include 30 minutes of classroom activities, followed by 30 minutes of like football skills and like small-sided games on the pitch. And football metaphors are used in the classroom to teach the boys about the mental health topics. So each week of the programme will cover a different theme around mental health. And on the screen here, I've got an example of week 1, which focuses on mental health awareness. So the aim of this session is to try and reduce the stigma around mental health problems. And for example, it will use a case study of ex-Premier League footballer and Wales football manager Gary Speed, who unfortunately lost his life to suicide only a few hours after appearing on TV programme Football Focus, where his behaviour appeared normal and he appeared just happy and chatty. So during this session, video footage from that TV programme will be shown to the boys, and then there will be a discussion around how anyone can experience a mental health problem and you might not necessarily be aware of it. And then this will be followed up by a range of different physical activities on the pitch, and that part of the session then is used to emphasise the key messages that have been covered in the classroom. So our early evaluation work of the Mentalk programme, it showed that the boys demonstrated greater empathy and more understanding of mental health after they'd taken part. So as we can see with the graph that's presented on the screen here, they would use a lot less negative and derisory terms to describe a person with a mental health problem after taking part. And we also found that they was able to differentiate between different types of mental health problems and show more empathy, and generally spoke very positively about the programme and said they would be something that they would recommend a friend to take part in as well. But that led to the rationale for conducting my PhD, as the published academic evidence in this area was fairly limited, and we was unaware how many other clubs or various sports clubs across the UK might be delivering similar programmes to Mentalk. So the overall aim has been to try and understand what types of programmes are being offered, how these programmes are expected to work, and what can be done to further enhance impact in the future. So the research has been underpinned by the UK Medical Research Council framework recommendations for developing and evaluating complex interventions to try and maximise their efficiency in use and improve their impact, and then try to replicate their effects more widely and roll this out then into various other programmes that might be offered to this age group. So a survey that was sent out to all clubs that are in the English Football League during the early stages of the research, we found that many clubs were offering mental health focused programmes to young people, but the type of work varied a lot. So some of the programmes would just be offering like weekly football or weekly aerobic activity to young people to enhance their overall like feelings of well-being. Whereas others would use a similar strategy to Mentalk, so they'd be using classroom sessions as well to educate young people on mental health. Whereas others would be partnered with CAMHS or other external mental health professionals to provide psychoeducation support to young people that were on a wait list for young people that did have a clinical diagnosis of a mental health problem and would be like on a wait list for receiving DBT. So doing that type of program, the mental health professionals would work with the coaches to deliver psychoeducation support at the football club grounds, with the idea that they could be providing support in an informal and relaxed environment for those young people. And then the coaches would be working alongside them then as well to try and encourage them to take part in activities. So what we found was most of these programs, they was focusing on enhancing overall mental health and well-being rather than trying to reduce symptoms of a mental health problem per se. But we wanted to explore this a little deeper. So I conducted interviews with 5 different trusts across the UK that were delivering various type of programs, including the staff that managed or delivered the programs, as well as the young people that had taken part. And the aim was to try and explore the possible impact that these programs might have on mental health and identify the important features that work well and can ensure best practice. So the interviews revealed that the programs could have a positive impact by encouraging the young people to talk openly about their feelings. So we found that conversations around mental health and just talking openly and being honest were really encouraged during these sessions. And the sessions would also then help to enhance the young people's learning and insight into mental health. But not only that, we found that the working closely with the young people would provide opportunities to identify those that might be at risk of a problem, and then hence ensure that they could be signposted to receive the necessary support. So for example, around encouraging conversations around mental health, one coach explained that they would use the sessions to be open and honest about the realities of looking after their own mental health, and they felt that this helped the young people to talk more openly too. So they would share experiences. They'd explain that they love the idea of meditating and they've got the Headspace app and they try to do it every day, but they was really honest about this, and they'd explain that even though they know it's really good for them, some days they fail. And they felt that this was a really accessible way then to give the young people a touchdown and encourage them to talk about their own experiences. And these discussions, we found that they had helped the young people to open up to the coaches as well as their peers. So one young person explained that they used to be a really closed off person, and the sessions had helped them to open their eyes to the benefits of talking about how they felt. And they felt they had really helped them a lot more than they expected it to. And then in a young person from another club, they explained that the coach that facilitated the program to them had made it a lot easier for them to talk not only to the coaches but to each other and their friends and their family as well. So from taking part, they also understood how to look after their own mental health and, for example, at the importance of being physically active. So one young person, they also had further enhanced learning and insight into mental health. And one coach identified that you could see over the course of the few weeks, they would begin to realise how serious developing a mental health problem can be and how important it is to look after your own mental health. And this quote from another young person from a different club, so they explained that the sessions taught them that you could be really famous and earning so much money and be really successful but still have a mental illness, but we don't see that because all we see is them having fun. So it was good to show us that. Sorry, I skipped ahead on a slide there. So the young people as well, they also was able to identify strategies to look after their own mental health. For example, with one young person explaining that they would feel really good about themselves after taking part in the football sessions, and they felt that it had helped them to feel better. And it was also able to help them to identify the different ways that you can find out whether you have like anxiety or depression, with one referring to the Gary Speed case study. And it was also found that the young people, they had more confidence then around knowing what to do if a friend or a family member was experiencing poor mental health as well, with one explaining that you want that person to be happy, and now you feel that you actually know what to do and how to do it. So these open conversations then would also provide opportunities to identify a young person that might be at risk of developing a problem, with one coach explaining that the sessions would lead to a number of individual conversations after the programme had ended, which they felt really pleased about, because it meant that the young person felt that they could trust them and wanted to open up to them and ask for that specific support. Whereas a manager from another club, so they explained, because these coaches would have a background in youth work and receive various qualifications with working with young people and mental health training, but because they would work closely with these young people over the course of the few weeks, they would get to know them quite well, and they could identify if there was ever a change in the young person. So they could sense if there was something not quite right, because they would get to know them. So a young person might generally be quite shy and a bit isolated from the group, and then all of a sudden they might be acting differently. So they can identify these signs, and that is where good youth work can kick in, because you can approach that young person and actually ask them, are they okay and what's going on, and then ensure then that they are provided with the support that they do need. So this meant that young people could be signposted to the necessary support depending on what was identified. And one coach who was delivering a programme in partnership with CAMHS, they explained that they felt that the programme was appealing for the young person because they was providing support in a community setting that was more relaxed and informal for them, and they felt that that helped to take away the stigma from receiving support as well. So based on the features of these community trust programs that we reviewed, there were several recommendations that we could see for ensuring best practice in programs that are designed to increase young people's physical activity and enhance their overall knowledge and understanding of mental health. So these recommendations could be rolled out to any programs that are attempting to combine sport with education sessions to improve mental health. So whether these are delivered in other types of sports clubs or youth club settings or as school activities. So first of all, it's really important to include sports or physical activities that the young people enjoy. So we found that whilst the status of the professional football club, that was seen as an important feature to the coaches, as it provided them with like an initial hook to grasp the young people's attention and build a relationship with them. Actually, what the young people had enjoyed is that it would include a sport that they enjoyed taking part in. So they saw the football games and skills as incentive for concentrating during the classroom sessions that would teach them about mental health. So therefore, if you're trying to deliver a similar type of programme, it's important to find out what types of activities that the young people would enjoy. And giving them this choice will increase their overall engagement and enjoyment of the programme overall. And we also found that club-related incentives as well, so things like providing free match tickets or T-shirts, that would seem to be another positive feature of the programme. So if sports clubs can provide this, then this can be helpful. But also a variety of different types of sports and activities is key. So the young people suggested providing more opportunities for different types of sports in the future. And the coaches also wanted to try and reach a wider demographic by providing different types of activities as well. They felt that this would help then to help the young people to try something new and find an activity that they enjoy taking part in, and help them then to overcome those barriers that they may have. And when we're thinking specifically with depression, so we know that inactivity can be a problem here. And it's important to remember that any activity is better than no activity. It doesn't mean that the young people need to be taking part in like intensive football sessions. So any way in which they can get active and providing them choice over something that they actually enjoy is the key thing here. Another important feature is using examples that young people can understand and relate to teach the mental health topics. So during the study, we found that references to sport were well received by the young people and helped them to understand the content and remain engaged. So like, as well as the case study of Gary Speed, other programs would include examples of like how well-known footballers had dealt with stress and poor mental health. So for example, a discussion around how David Beckham experienced difficulties with his mental health during the 1998 World Cup game against Argentina, where he had a red card and was dubbed like the most hated man in Britain. So for example, that is used as a conversation for the young people around managing stress and anxiety, and trying to explain to them that everyone can experience highs and lows in their life, and it's really important to build resilience and find ways to look after your own mental health, but also to feel comfortable to open up and ask for that support if you do feel that you are struggling. So therefore, it's important to use examples that young people are interested in. So again, this doesn't necessarily need to be specific to sport, but other well-known public figures could be useful. So like TV stars, pop stars, actors, and so on. So again, it means it's helpful to consider the target audience for your programme and ask them what their interests are and what they would like to see. Another important feature is that the person that delivers the session should be relatable and a positive role model for the young people. So the Community Trust, they would recruit coaches that would have a background in youth work and receive various qualifications as well as mental health training. But often they would try to recruit coaches that were young themselves and from a similar background to the young people, as well as recruiting like female staff to deliver their girls only programs. And this was seen to be a positive feature. So the young people, they really appreciated that the facilitator would speak to them like a mate and that they didn't see them as an authority figure. And it was frequently mentioned that facilitators that were relatable and good at interacting with the young people would lead to better attendance and engagement. It's important to note as well that regular training is needed. So the coaches really appreciated the mental health training that they had received, as it helped them then to identify the signs and the risks of a young person that might be experiencing a problem, as well as feeling comfortable and confident to deliver those mental health education sessions. But it was important for them to receive regular refreshers to ensure that they did have the most up-to-date knowledge as well. So as we've seen, so another important feature is encouraging open and honest discussions around mental health. So this was seen as a positive feature, as it could encourage the young people to open up and then lead to identification and signposting to further support. So we found that it was key with this type of program that the facilitator should feel comfortable sharing like personal stories and like advice and tips on how they look after their own mental well-being as well. And lastly, we found it was important that the classroom session should include interactive activities as well. So whilst overall engagement was high, some coaches would experience difficulties engaging the young people for long periods of time during the classroom. And the young people explained that sometimes they would find it difficult to concentrate. So they really appreciated whenever there was opportunities for like peer-led discussions to break up the talking. And they also really enjoyed like interactive activities like creating posters and post-it notes and drawing and so on. So I've highlighted a few further websites that may be of interest. So one of the links as well is for the English Football League Trust. So for example, if schools or any external organisations are interested in partnering with clubs to deliver these types of programmes, I'm aware that coaches are always looking for other ways in which they can deliver this type of work. So you can access that website to see the type of work that might be going on in your local area as well. So if you do think that might be something of interest. And there's some additional references that I referred to, as well as our systematic reviews of all types of physical activity programs and the impact that these can have on young people's mental health. So not just those that are delivered by professional sports clubs. So thank you very much for listening. I can see that Sam is here, so
perfect timing, Gabrielle, perfect timing, and lots of positive comments. It really was a great presentation, and I love that actually you talk about physical activity, of which exercise is a component, but not the only thing. I think that's really important, the language we use. And also the fact that it's not just about the physical activity, it's everything that comes with it, isn't it? The connection, the belonging, the conversations, and has, you know, sports saved my husband's life, so I'm very much an advocate of that. So we have got some questions for you, Gabrielle. If you could hang around to the end, that would be absolutely wonderful. If you could unshare your screen now, that would be wonderful.
Yes,
we are now moving over. Let me get my screen out of the way, to the wonderful Nicole, who is here to talk to us about the PIPHPA trial. And then she's going to be followed by Kirsty, who's going to talk about it within her setting. So welcome, Nicole. Looking forward to this as well. Over to you.
Thank you very much, Sam. I'm just going to share my screen. So if you could let me know once you're able to see it, that would be brilliant.
I can see it, yes.
Fantastic, thank you. So as Sam said, I am Nicole. I'm a research associate currently based at the Warwick Clinical Trials Unit, and I'll be talking to you today about the PIPA trial, which is looking at an online parenting intervention to prevent affective disorders in young people who are at high risk for depression and anxiety. So a little bit of background to the trial first, and as we've heard from Irina and Alex, and Gabrielle, we know that there's a significant percentage of young people who experience mental health difficulties, and research suggests that around 50% of adult mental health difficulties emerge and become established by the age of 14. So we know that this is a critical period for young people and their development. And we know that once these difficulties emerge, that early intervention can really have a very significant and very positive impact and prevent long-term difficulties in behaviour, in psychosocial factors, and in vocational factors as well for young people. And we know that families are well placed to notice changes in young people's mental health and also provide immediate support, but they might not know what the best way of doing this is. Schools also play a very important role in supporting students with their mental health and well-being, and I can see in the chat that we're joined by lots of pastoral care and mental well-being support staff from schools as well. And we know schools provide lots of interventions within school, and it's really important that schools and families work together to provide support for young people, because we know that establishing these good support networks and establishing them early on and providing support when these difficulties first emerge can be really, really important in terms of later life outcomes as well. So we know that research indicates that there are risk and protective factors that contribute to adolescent mental health, and Alex and Irina have both discussed some of these, and our colleagues in Australia, Marie Yap and her team, have done extensive research into risk and protective factors linked to the family system that have a bearing on adolescent mental health and well-being. So they've done lots of research, they've done a consensus of experts, and they found certain factors that are modifiable within the family system that have an impact on young people's mental health. And what they've done is they have developed a set of guidelines and strategies for parents based around these factors, So things like establishing and maintaining good relationships, communication is a key one, and being involved in young people's relationships, but also encouraging independence, and further things like minimizing conflict and encouraging good habits. So they've developed these set of guidelines, and they've also developed what is called the Partners in Parenting program. So this is an online interactive program which provides information about young people's mental health and well-being, and it's geared towards increasing families' awareness of mental health and well-being, the ways in which they can support their young person, and really what it's trying to do is build skills and confidence for families to support their children with difficulties with mental health and well-being. So when they're experiencing some signs of depression or anxiety, families will be able to start talking to the young people, will know how to start supporting them. So Marie Yap and her colleagues have conducted a randomised control trial of this programme already in Australia, and they found that parents who received this PIP programme reported greater improvements in their parenting, and also that these improvements were maintained 1 year later, and these parents also reported reduced depression symptoms in their children. So the PIPA trial, what we've done is we've taken this Partners in Parenting programme, we've adapted it for use with UK families, and we're trying to find out whether this online resource will be helpful for parents and carers in reducing depression and anxiety in young people. So we've got 2 different online resources, and we're aiming to identify whether a personalised programme or a standard educational package is most effective in helping families. So the resources are designed, as I said, to improve families' knowledge and awareness of mental and emotional health, and also share practical tips and strategies that they can use at home in supporting their young person. So the first resource is called the Personalised Programme, and it consists of up to 9 interactive modules, and they cover all of these different areas of parenting and family life. So the first one is all about communicating with your young person, and then we go on to managing conflict, managing anxiety, and help seeking. And I've put some screenshots there of one of the modules so you could have a look at it. So in the first instance, what parents will do is they'll complete a parenting survey, which looks at their parenting style. And based on their responses to that survey, they'll be recommended a set of these modules. So they can opt to do a few of the modules, or they can do all of the modules. And based on the topic of the module, there's lots of information. So for example, the communication module gives you lots of tips on how to start a conversation with your young person, little key phrases and questions that you can ask to find out more about how they're doing. And the modules also have some video scenarios that parents can watch, particularly Managing Conflict one I know has a video on that. And there's audio clips of young people talking about their experiences as well. So each module ends with a little quiz and also a goal setting activity. So parents will pick a goal to work on for the next week based on the things that they've been reading and learning about. So it is really encouraging them to be engaged with the things that they're reading and be proactive in putting into practice these tips and strategies that they're reading about. Our second resource is the Standard Educational Package, and this consists of a series of 5 fact sheets regarding teenage development, well-being and resilience. So I've popped some screenshots there for you to have a look at as well. And this is the typical sort of information that families would get, what's out there already. So for example, if they're help seeking from their GP or a support worker and they want to find out more about mental health and well-being, this is the typical sort of information they'd receive. And the key difference between this and a personalised programme is the Standard Educational Package is not interactive, it's not personalised, it's the typical sort of information that's out there already. So those are the 2 resources that we're trialling in the trial. And as I mentioned, it's really important that schools are involved in supporting young people, and we know that they are. And that's why the PIPA trial is working with secondary schools across the UK in order to help us engage with families. So schools sign up to take part in the PIPA trial. We provide them with an information pack about the trial, which they provide to families. and then families register with us in order to take part in the trial. And we're guided by schools as to the best way of engaging with families. So it could be, you know, any one of these methods. And what we've found is regular promotion is always helpful. Families then know that this is a resource that's available if they need help, or if they want to find out more information, that they can take up this offer as well. And we know that one size doesn't fit all when it comes to interventions and resources. All families are different. So it's nice that schools are able to have just another resource available that they can provide. And we know, as you know, Gabrielle said, after COVID, there's been a major increase in mental health difficulties and the need for support. And we know schools are really struggling to provide that support due to capacity, due to lack of resources. So we're hoping that the PIPA trial is something that will be helpful for schools. That's not too much of a burden on them. We don't expect schools to do a lot of work for us. So yes, we hope that it's a helpful resource for schools. And what we really want to achieve is helping them forge positive relationships with parents and carers. We know that schools, you know, have really good relationships with students, but it's really important to bring the family into that as well, and help families increase their own capacity to support young people with their mental health. We know there's lots of interventions and resources out there, but it's also important that we have a really good evidence base for how they work and do they work. So it's really great that we're able to involve schools directly in evidence-based research to improve youth mental health. So I'm going to talk to you a bit about who can take part in the trial, and also, you know, what families will be doing when they take part in the trial as well. So the trial is open at the moment to families aged 11, to families of young people aged 11 to 15 from across the UK. And we do have some eligibility and screening criteria. So young people will complete an emotional wellbeing questionnaire, and we've set a fairly low threshold because we're coming from an early intervention perspective. We're looking at young people who are at risk of developing depression or anxiety, or are just starting to develop these sorts of symptoms. Now, that's not to say that if they do have an established diagnosis, or if they're already in touch with services and receiving some support, they won't automatically be excluded. They're still welcome to take part as well. And one of the really nice things about PIPA, given the pandemic and lockdown, is that everything is conducted online. So families don't need to do any face-to-face visits or meetings. They work through this on their own time, whenever they've got the time, and they just need access to the internet and a device in order to be able to take part. So once families have received the information from school about the trial, the parent will sign up and say that they are happy to take part and that they're happy for their child to take part. And then we'll check with the young person as well if they're happy to take part. If they are, they'll complete the screening questionnaire, and then eligible families will complete a questionnaire pack, which goes into more detail about the young person's mental health and well-being, their quality of life, their use of services as well. And once they've done that, they'll be randomly assigned to either the personalised programme or the standard educational package. And this is where the work comes in for the parents. So they will work through either the modules or the fact sheets, one per week, and work through all of them within about 2 to 3 months. They'll be doing that. And then we're also going to follow families up at 6 and 15 months, because we want to see if there is a long-term impact of the resources on, you know, the young person's well-being. There is support for parents and carers while they're working through the trial. So as they're going through the modules and the fact sheets, they'll receive a fortnightly check-in call from our research team. And this is just to see how they're getting on. We can provide support and guidance while they're completing the online resources, and obviously, you know, to troubleshoot any technical issues as well. And the trial, you know, something to highlight is that we do have duty of care procedures built into the trial. So we often, get flagged that young person is experiencing high levels of depressive symptoms, or there's an indication that they've been self-harming, or there's some suicidal thoughts, and those get flagged to the trial team. And we have duty of care procedures which involve making sure that the family are aware of the situation and that they also know where they can go to seek support. And we sometimes get schools involved as well in, making sure that they're aware and that they can provide some support to the families as well. And, the resources are really designed to improve families' knowledge and awareness of mental health and emotional well-being. It's really trying to help them find out what is quote unquote normal teenage development and changes in their emotions and in their behavior, and what is something that's a sign of more concerning difficulties. So it's really trying to help them identify difficulties early on, and also providing some tips and strategies on how to engage their young people in conversation about this, do activities with them, things that can really help and support young people. So the outcomes for the trial, our primary objective is to test the effectiveness of the personalised programme in comparison to the standard educational package on the severity of depression reported by young people. So that's our primary outcome, but we do have some secondary objectives. So we will be looking at the effect of the resources on parental behaviour, on their self-efficacy and confidence. We'll be looking at the effect of the resources on young people's anxiety, emotional and behavioural difficulties, emotional regulation as well. And we'll also be looking at if there's been an impact of the resources on the parents' own mental health and well-being. And we have a health economics evaluation as well to look at the cost effectiveness of such a programme. So we're really trying to identify whether the online resources, whether they're effective in supporting families and young people, and whether it's something that can be rolled out more widely and be a resource to support families. So as I said, the trial is currently open to recruitment, and we have faced a few challenges. And the first one, and the biggest one, was COVID for us, as I'm sure you're aware. The pandemic hit just as the trial was due to open to recruitment, so we had to pause all activities until the schools were back open, so we could open the trial as well. And once schools did open, there was a massive increase in workload for school staff. There were so many competing, priorities, and it was initially difficult for us to engage with staff. But as the need grew out of the pandemic, as we saw, there's massive increases in mental health difficulties, and services have become really overwhelmed with the need for support, and schools were bearing the brunt of this with young people as well. So as the need grew for support, we've had many schools come on board that were really keen to have an additional resource for their families. But we did have to find a different way of working with them. So it's been lots of online meetings and drop-in sessions. We were, initially we were recruiting from just Birmingham and Coventry. We were doing school visits. We were on the ground speaking to staff, but unfortunately we couldn't do any of that anymore. So it's been very interesting. There's been a lot of adaptation, but out of that, we've now started recruiting across the country, and we're working with so many schools that have been brilliant. And I can see in the chat that there are a few schools that are Pippa schools here as well. So hello to all of you. We also found that mental health is now becoming more ingrained within school ethos. So we found that there's lots of mental health support staff, and it's something that's really becoming a hot topic at the moment, as it should be. And that's been one of our targets, is trying to work with mental health and wellbeing leads. We've been working with local authorities and multi-academy trusts, really trying to build connections with schools to provide this resource, because we know that it's something that schools can engage with easily. And we know schools are wary of engaging with lots of resources. You get lots of offers, I'm sure. And the biggest pressures are time and cost. And with the Pippa trial, we've tried to minimise the burden on schools as much as possible, so there isn't much engagement required, and of course, as it's a research trial, there isn't a cost for schools as well. So we found that engaging with schools is fairly easy once we got over the initial hurdles, but engaging with families has, of course, been a bit more difficult. And we know that schools find parental engagement difficult anyway. So what we've been trying to do is trying to have a PIPA champion in each school that can talk about the trial, that can answer questions for parents. So putting a face really in the school that can talk about the trial and encourage parents to take part in the trial. And then we know that with families themselves, time and capacity is a big difficulty, and that's where it comes in, being an online trial that parents can work through in their own time. We hope that that's something that will encourage parents to take part in the trial. And we also know that mental health can be a difficult topic. It can be something that parents find difficult to discuss, difficult to seek support with. And often when young persons initially, present with difficulties with mental health and well-being, parents can feel helpless, not knowing what the best way to support their young person is. Often they can be disillusioned with services. We know about long waiting times and difficulties, in reaching out to services. So these can present as barriers for families taking up offers of support. But we hope that the trial will, encourage people to take that, it's sort of like a stepping stone. They're taking a first step towards empowering themselves and learning more about their young person's development, their mental health and well-being. And hopefully through this process, they'll understand that there is support available. There's things that they can do themselves. And there's also people and organisations that they can reach out to for further support. And then one of our final barriers is keeping families engaged. So once families sign up to the trial, their duration in the trial is 15 months, which is a really long time. So it's a little easier to keep them engaged while they're completing the modules and the fact sheets. But then, we have to keep them engaged for 15 months to ask them to complete the questionnaires. And so families are able to access the online resources until the end of the trial. And we encourage them to revisit the resources, and we provide, regular reminders and things like that to really keep the families engaged, and, encourage them to put into practice what they're learning about as well. So I'm going to finish off talking a little bit about the current recruitment for the trial. So the PIPA trial has been open to recruitment since February of 2021. And to date, we've had 207 schools across the whole of the UK, including England, Scotland, Northern Ireland and Wales, who have registered an interest in taking part. Of those schools, we have 124 that are currently open to recruitment, and we've had 359 families who are taking part in the trial as well. So recruitment is due to end for the trial at the end of March, and the trial ends completely in November 2024, when after that we'll be publishing the results of the trial, which will be available on our website if anybody is interested to find out how we get on. So our main source of recruitment for the trial has been through schools, as you've seen, but we do also have a recruitment route for community organisations and individual families that would like to take part as well. And you'll see information about all of that on our website on this final slide. So if you do have any questions about the PIPA trial, please do pop them in the Q&A function, and you can email me directly as well. And if any schools would like to take part in the trial, please do get in touch. And thank you very much for listening.
Thank you, Nicole. Over to you, Kirsty.
Yeah, thank you very much. Hopefully you'll be able to see my screen in a minute.
Yeah, we've got your
screen. See that. Fantastic. I feel hugely privileged to be here amongst such amazing experts, actually. It's been a massively busy week in all our schools promoting Children's Mental Health Week. So it's really quite wonderful to be here tonight and talking to you from a school perspective, but also to say how our school is linked with a brilliant PIPA work at Warwick University. My presentation, very short presentation, is not intended to teach anyone to suck eggs, but just to really demystify what schools are typically doing. And I know I can see in the chat many of my school colleagues, and I really want to champion everybody working in schools right now, and everything that everybody's doing to support young people with their mental health. So I'm Kirsty Oliver, I'm the Deputy Head at Humphrey Davies School, and as you just saw on Nicole's slide, I'm the school right at the very end of Cornwall. We can see clusters all around the country, and I'm the one at the very end there in Cornwall, absolutely championing Cornwall. We're an 11 to 16-year-old school with 800 plus students. We do actually have a very high level of students that are identified as vulnerable, who have additional needs. A very high percentage of our students, 30+%, are on free school meals. It's been a massive increase since COVID, and we are way over sort of 13% high above the Cornwall average as a school. And we do know that our children do have quite difficulty in terms of where we're from. Whilst it's a beautiful place to live, it is also classed, Penzance, as one of the most deprived areas in England. So just moving onwards with my slides, anybody working in school will know that looking out for children's mental health it fits into the safeguarding responsibilities of all staff. And preventing damage to children's health or development is now part of the 2020 Keeping Children Safe in Education, which explicitly includes mental health in the definition of safeguarding for the first time. So we're all acutely aware as people working in schools that by supporting students' mental health, it's linked in with getting them the best outcomes and those essential tickets, as I refer to GCSEs, or anything, skills-based for life beyond school that open those doors. And we're acutely also aware that mental health needs can leave children more vulnerable to abuse or be an indicator of abuse. So we're always looking out for signs of poor mental health. And by acting on them, we know that this therefore helps protect children from maltreatment and ensuring that they're safe and have effective care. I'm always conscious to remind school staff that whilst they're not trained professionals in mental health, they still have an incredibly important role to play in being alert to signs, to be present, to be emotionally available, and also to act on worries, as this can obviously feed into a wider mosaic of information so that we can get them support in a timely manner. I'm not going to sort of go over this too much because other colleagues have already talked about risk and protective factors. But we do know in schools that those are the areas that we see in school. And it stands to reason that, statistically, whether they're more likely to have poor mental health or more likely to have good mental health, according to those risk and protective factors. Additionally, we're aware that students with SEND and those that are identifying as LGBTQ+ would also fall into us understanding how we can support them through their journey or through the support that they require. We also, unsurprisingly, if I talk about family and the link with the PIPA trial, family can be a massive influence, we know, on mental health, and sort of conversely with a risk and protective factor, that we know that poor parental mental health, for example, family circumstance, cost of living, etc., can be a sort of risk factor, or conversely, parents who can share and demonstrate coping strategies that they've honed or learnt, and obviously linked in with the PIPA trial, can be quite a sort of protective factor. So we ask staff to be very curious, I suppose, around crafting mentoring discussions. And all of our students in our school have mentors that are able to have sort of those coaching conversations. For example, is a student struggling with academic and exam pressures? Do they have any physical health issues? Are they resilient? Does their family have any current or previous financial difficulties? How stable, how supportive is their family? And although our staff can't necessarily fix some of these risk factors, they're alert to them and they're aware of the higher risk of mental health needs for the children affected. So these are some of the potential indicators of poor mental health in normal sort of secondary school children. I'm sure I've missed things from there, and I really sincerely hope there are no spelling errors. But we have, like I said, we have key adults in school, our mentors, and they would look out, obviously, for those changes in behaviour, emotions, and they're very acute. They really know our young people, and that's the whole driver. We want every young person to have a key adult or adults who know them well. They'd be looking for those physical signs, self-harm, not eating as much, having less interest in the things that they usually enjoy, being increasingly isolated, withdrawing, having less engagement, not developing as well as they were previously, maybe in a previous year, less interest in school, having less interest in friendships, maybe not doing as well performance-wise, or attendance concerns, obviously key indicator, or refusing to come into school, low mood, being tearful, or low self-esteem. And I know schools run sort of various guises of the things that we're doing at Humphrey Davy School, but the way in which we glean, we share, and we signpost, we have parental contact, talking to parents. We have a CARA group, that's Cornish for Care, and our restorative ambassadors, our well-being ambassadors. These are student peers that will talk about that information and pass that information on. We have My Concern. Other schools might use CPOMs. We have pastoral huddles regularly, weekly, to talk about key students and concerns that we might have. Causes for concern was something that we added to our school behaviour sort of SIMS just after COVID, to be able to have an indicator of how those students were doing. And a pastoral bulletin, which is accessible to all staff, just to say, if a child is going through a recent bereavement or a family breakup, so that there are more staff across the school that are aware of the information that is needed to be shared. And that all adds to that massive mosaic of information. And obviously, we're alert to change, the main thing, whether it's physical, emotional, school performance, etc. And again, whilst we're not experts, we have placed a massive emphasis on staff having the tools to understand the teenage brain more, giving that directed time to our staff to support staff training, the teenage brain. How does it work? What do we need to be aware of? And also, how does our language, how can we use our own sort of low arousal and access to language to support them at this essential time when their brains are developing at a massive rate? We've also done a huge piece of work. Head Start Kernow have been phenomenal in training support staff across Cornwall in trauma-informed practice, and our links obviously with trauma-informed schools. And we've made a massive effort to train all of our staff with PACE. And PACE is a way of being, it's a way of talking. And you'll see there in the middle, it's playfulness, acceptance, curiosity, and empathy. And we give little sort of cards. Everybody wears a sort of lanyard in school, and in the back of their lanyard, they have starter sentences for PACE to generate those questions and that curiosity in understanding how a child might be feeling at that particular moment. And we also have sort of cards that we'll have with restorative conversations as well. That's a fantastic, I'm just to talk very briefly about our curriculum, because all of this we need to underpin with a really rich and inclusive curriculum, which weaves at appropriate age-related ways in which we support mental health for all our young people. Boing Boing there is a wonderful way. And how do we translate that as a school? Well, in multitudinal ways. We have every half term, we have a mentor map of the ways in which we can respond to issues, respond to key points in the school year and the annual year. How do our assemblies link in with our social, moral, cultural and spiritual curriculum, our British values, etc., and careers, aspirations? That all links into a mentor slide. I know many of my colleagues in school will have been promoting Wellbeing Wednesday, which is a fantastic way of introducing that into our mentoring. And we have tons of teaming with resources in the background there. We've also got our curriculum map. We have a citizenship and personal development curriculum, which kind of weaves its way up. And in a sort of cyclical way, we come back to themes to make sure that we give those children a toolkit that helps them through their way and anything that they might need to cope with along the way. Alex Boyd talked a minute ago about young people that feel cut off from the world. And one of the things that we were keenly aware of was introducing a sort of sense of belonging in schools. So finally, for me, we're talking about the pyramid of need and the ways in which we would sort of encourage our school ethos, preemptively supporting our children from low risk to high risk. And so that brings me neatly onto the PIPA trial. The PIPA trial is something that we were aware that we had a deficit model of our parents being able to work in partnership with us, with our young people, to give them the tools that they need to support them through life, post-16. And so we have it on our school website. We promote it regularly, surreptitiously, with targeted groups of parents that are, in various areas of our pyramid of need. And there it is. just there. And I would encourage other schools. It's in a world that has become very much more accustomed to working online. The Pivot Trial offers that access to our parents in a brilliantly unthreatening way. And the feedback I've had from some of our families is it's really quite a superb tool as well. So thank you from me.
Thank you, Kirsty. Honestly, it sounds amazing. And I love you. I want to come to your school. I wish I worked in your school. I'd probably stayed in teaching a little bit longer than I did. Okay, so we've got a load of questions. Now, as chair, I've made a decision to generalise some of the questions because we can't get too specific. So I'm hoping I don't annoy all of you or some of you and that we get the questions in. The first person I'm going to go to is Irina, if you're there. Who was obviously first. Irina, we've had some questions about a lot of the research seems based on typical family dynamics, and that in society today we have a variety of family dynamics with different genders and biological sex involved in parenting, and also that a lot of the research seemed to focus on maternal depression rather than maternal absence. Just interested to hear your thoughts on that.
Yes, absolutely. Thank you so much for this question. So the analysis that I described in my talk, they mostly arise from the secondary data analysis. So we're often driven by the kinds of data that are available. So the prevalence of father absence in Alsbach is actually relatively low, and it somewhat matches the national UK statistics. So it's about 10%. And when we looked at the absence of mothers in Alsbach families, it's even lower, so it's below 3%.
Okay. Sorry, carry on.
Yes, sorry. So I was just going to say that, you know, it's a very small subsample of families, and we really didn't have any statistical power to examine potential effects reliably. And I think actually in UK, you know, if we look at the overall statistics, the majority of single parent households are headed by the mother. So it's about 90%. So I think what we're observing in Alsbach data is quite representative of the national averages.
Thank you. And how does it sort of link with countries abroad, you know, internationally? Have you seen as the data similar internationally to the UK?
So in my research so far, I haven't done any cross-cultural comparisons in terms of the adverse effects of father absence on mental health. But previous research looked comparatively by using the meta-analytic technique at the effects of father absence across different countries, albeit predominantly in Europe and North America. So the results are quite unanimous that father absence, divorce, parental divorce and separation are associated with adverse mental health outcomes in children across the lifespan. So not only just at one point in time, but at different points in time across childhood, adolescence and going to early adulthood.
And it's so interesting. And somebody also asked, you know, has there been an increase over the last 20 years? Or has it remained the same?
Yeah, so what epidemiological evidence suggests so far that overall over the last 20 years, there has been an increase in rates and prevalence of mental health disorders in children and adolescents. So what drives this increased risk is still unknown. And I think I mentioned that in my talk, that sort of the field of psychiatric epidemiology is trying to move away from identifying rates and prevalence of mental health difficulties, but rather understanding what are driving this quite dramatic increase. So we can only speculate, and based on existing evidence, that it could be proliferation of social media, it could be increased rates of eating disorders and body dysmorphia, and sort of access to self-harm images. So, but these are just kind of hypotheses that haven't necessarily been borne out by existing evidence.
Thank you, Irina. I'll probably come back to you if we've got time because there are more questions. I'm going to move on to Alex now, if that's okay. Are you there, Alex? Alex, are you there? Wonderful. We had questions about neurodiversity with regard to depression, recognising it with regard to what treatments are available, particularly, you know, around the ASD, ASC side of things. What can you say? Tell us about that.
But without doing a full other webinar,
Yeah.
I guess the starting point is that I guess the research shows that young people do experience depression in a slightly different way, and that they'd be more likely to, you'd be wanting to look at individual factors. I think with any young person who's depressed, you want to be looking at individual factors in them. But I guess it's thinking a little bit more about potentially their sensory regulators. What are other people noticing?
Oh, you're muted.
Sorry, just accidentally
okay.
muted myself. You know, that it's more likely that they won't be able to describe what they're feeling. So you might be needing to think differently about engagement, and that not being asking these questions in the same way. You might need to think about other ways to gather information, such as the use of characters, specialist interests. There might be video games, you know, some of those nice examples that were coming up in the chat and Gabrielle talked about within football would be a really good way to kind of link and access. I guess when you look at more specifically at the research as to how depression presents in young people, particularly with autism, you might see more social withdrawal, more changes in their interests, maybe lack of interest in what they've previously been interested in, more preoccupation with death and dying, and potentially a lot more irritable and agitated, and that you might need to rely on more people around them to help them recognize that than potentially them. But everybody's individual, and every part of neurodiversity is individual, so it's kind of hard to, but you know, what's you know, the number one thing to hold in mind is what's normal for that young person and what feels different, and that's your indicators for all young people, really.
And sort of treatment then, treatment plans for autism spectrum condition children and getting them to engage. What is your advice or experience around that?
I think firstly, you want to be thinking a little bit around, you know, how possible that bit is to begin with. It might be more about regulation and, you know, if the young person is also experiencing a significant degree of burnout, how do we mediate some of those things? How do we take off some of those external pressures and think about clearer structures to support them before engaging in more traditional psychological therapy, I guess. And I guess some of the literature looks around again, doing something in a different way. You might not want to sit face to face with somebody. You might want to be out. You might want to not have to talk. You might want to be drawing. You know, it would be utilizing the young person's individual approaches. And I guess a lot of the research looks towards understanding feeling states and kind of coaching around thinking states if the cognitive part is important for them. But I guess with any psychological treatment, you'd be wanting to think a little bit about understanding that particular young person's difficulty, creating that formulation, and then the treatment coming from that.
And we've also had a few questions about sort of arts-based therapy, EMDR, PET-assisted therapy that schools can use. All sort of, I mean, EMDR is obviously more specialist, but they all shown to have good outcomes for young people with depression.
I would say yes, but I'd have to look a bit more at the literature to really back that up. But yes, I think any opportunity for young people to be able to understand what's happening and explain what's happening is a way of getting help to what's happening. And particularly in the context of depression, when you're talking a lot about social, you know, we understand social withdrawal, the sleep, the apathy, the not being able to, that feeling confused, and then, you know, add in some behavioural activation, and that's even better. You know, nice guidelines would look at that, but it'd also look at kind of adapted cognitive behavioural therapy and family therapy.
And I was thinking behavioural activation is quite similar to the social prescribing and the sort of physical activity and the engagement. It's all underpinned by sort of the same principles.
Yeah, and actually one thing to mention is the Books on Prescription scheme, which been in operation for many, many years for adults. A couple of years ago, launched for young people as well. So every library in the UK should have a catalogue of mental health focused stories, as well as self-help books under the Reading Well scheme. So, if young people and families and parents and teachers can go to their local library and find things like Starving the Anxiety Gremlin and or Depression Gremlin, that's the other one, and self-help books that think about that, as well as novels that relate to understanding mental health.
Thank you, Alex. We've still got more questions coming, so I might come back to you. If I can go to Nicole here as well. I feel like I'm like at the Eurovision Song Contest here, going to each country to get their sort of... and we go over to Austria with Nicole. We were asked about pupil premium, and maybe Kirsty can answer some of this as well. Using pupil premium funding for mental health supported interventions. Do you do that, Kirsty? Nicole, what's your experience of that?
I think Kirsty can answer that question better than I can, being in school. But just to say that PIPA is a free resource because it is a clinical trial. It's free for families and free for schools to take part in.
Yeah, and just I suppose on the front of using pupil premium money to support young people, it's very much embedded within the sort of resources that we have in schools. So I would think, the way in which we've got our student support workers, or in other schools, pastoral workers. We have TAs that we train to use Draw and Talk, for example. We have a school counsellor. We invest in Forest School with those young people in year 7 that we're aware that need that preemptive way of sort of working. We have arts therapists that we use, and we use, sort of that funding. We have youth workers, youth projects, something called Hale Youth Project down here that we use, and enrichment, that, like I talked about, that sense of belonging. So pupil premium funds in order to sort of, create other enrichment opportunities as well. So yeah, there's a myriad of ways, just sort of off the top of my head.
That's it. And I have to say, I've heard such great things about Head Start Curnow as well. Being in Devon, a lot of people are jealous of Head Start Curnow in Cornwall, because it's just, such a fantastic organisation and support.
Yeah. And that resources, that's for anybody to access that.
Yeah, absolutely.
Quite a lot of training on there as well.
Go and look at the Head Start Curnow page. Highly recommended. Thank you, ladies. I'm going to go back to Irina now and ask a question about any research with regard to parenting style. So perhaps with regard to narcissistic traits from parents. I've seen some research linked to anxiety of authoritarian parents or helicopter parents. Is it similar with, I know you touched upon this in some of this in your research, but is it similar with parental style?
So this is not something that my research addresses directly. So in some of the studies, that I've described, so we looked at some of the specific maternal nurturing behaviors that are centered around looking after the infant sort of very early on in infancy. So in terms of how this broader parenting style constructs are associated with risk of mental health in childhood and adolescence. So my understanding is from existing literature is that kind of more harsh and authoritarian parenting styles associated with increased risk of mental health. So from my own research, what we're seeing is that definitely higher levels of parent-child conflict, are strongly associated with increased risk of mental health difficulties at different points in childhood and adolescence, and that for both mothers and fathers. So higher levels of conflict and harsh discipline are certainly strong risk factors for negative mental health.
Thank you, Irina. And I think it's important, the language you use are risk factors. It's not causation, it's correlation, what we're talking about here. And, increased risk factors are not predeterminate outcomes.
No, absolutely not. So the studies that I presented today, so they're not claim causation whatsoever. They suggest correlations and associations, of course.
And a lot of people struggle sometimes, I think, with that link. Thank you very much.
Yeah.
We're going to go to Gabrielle now. We've got Gabrielle, a 15-year-old, doesn't want to do physical activity in school, and he doesn't want to do his PE lessons. This could be me. And any recommendation, advice to motivate or encourage to take part in PE lessons?
Yeah, okay, so well, that's actually really interesting as well, because that was very much my experience at school. So I really didn't enjoy PE. And I think it's really important to encourage the young person to find an activity that they enjoy. So particularly if a child is very shy and reserved, perhaps, or has low self-esteem, they may not enjoy the team element of taking part in sport. So I think encouraging them to try out different things that they might find useful. So simply just walking to school, or taking short activity breaks throughout the school day. Individual sports can be helpful, so things where they just participate in by themselves. A variety of different activities, swimming. I think it's important to encourage them to try different things and make it clear that there isn't a one-size-fits-all approach, and they need to take part in something that they find enjoyment with. And it's really important to give them the choice, and then they're going to want to encourage and take part then long term.
I think that's the key. And, you know, when I talk to a lot of PE teachers about being inclusive, it's you've got to motivate them to want to come. You know, why would they come if it's not an enjoyable or a pleasurable experience about it? We have to look at what we're doing as well to make it more attractive to them.
Yeah, and I think if it can't be offered like through PE at school, like offering more like after school programs. So I know like some of the programs that we've looked at in the systematic review, they would offer activities like as part of a healthy breakfast club scheme. So it would be things like jogging, for example, and then some young people may realise that they prefer that element. So I think, yeah, giving them the choice really is key, and making it clear that just because they don't enjoy, you know, rounders or football, it doesn't mean that they are then destined to have a sedentary lifestyle. It just means that they haven't found what they like doing.
Love it. Thank you so much. And Irina, you seem to be the most popular with questions. I'm so sorry to feel if I'm bombarding you with this. People just don't want you to go. I think we know potentially the answer, but somebody's asked about the links between living with domestic violence and depression.
So again, this is not something that I touch in my research directly, but kind of thinking about existing literature. So high levels of parental conflict. So interparental conflict is definitely a strong risk factor for mental health difficulties in children. So by proxy, I would have thought that living with domestic violence and often kind of results in psychological or physical abuse, I would have thought, you know, is also strong risk factors for mental health difficulties.
Thank you so much. Thank you, Irina. I'm going to draw it to a close now. I know I've left a couple of questions unanswered, but they are very specific about research. So I suggest perhaps you contact Irina to ask those questions. And I know a lot of people are having to go, but the comments, everybody's found it useful. Yes, remember, you will get the slides and the recording of today. I really hope you found it useful. I've certainly found it useful. Thank you to all the presenters, Irina, Nicole, Kirsty, Alex, Gabrielle. Absolutely wonderful. Just really, really interesting, beautifully put, and absolute delight to work with you. I'd like to say thank you to Terry and Charlie for being some of the main organisers with this, along with the staff at ACAMS. And look after yourself, and remember, join ACAMS because it's brilliant, and hopefully we'll see you at future events. So take care. Goodbye.
Find out more about becoming an ACAM member and to be part of the advancement of child and adolescent mental health. Visit www.acamh.org.